Good evening and good at the Hadassah Medical Organization in Jerusalem. I'm delighted to welcome you to this event.
Yes, I'll hang up, George.
Thank you. I'd like to introduce you to Professor George Breitberg, who will be moderating this webinar. George is Professor of Medicine, Emergency Medicine in the Department of Medicine at the Royal Melbourne Hospital and the University of Melbourne. He's also the Emergency Medicine Head of the Centre for Integrated Critical Care Medicine in Melbourne and Executive Director of Strategy, Quality and Improvement at Melbourne Health. George.
Thank you. Thanks for everyone for joining. I think this is going to be a really entertaining next hour. As moderator, I just want to introduce myself and also some rules for this participation. Everyone will be muted by the organizer, and if not, please place yourself on mute. There will be 15 minutes of questioning at the end of the session, so after 45 minutes. But because of the number of participants, question and answers will only be done by using the chat or comments section in Zoom. And hopefully, if you look down the bottom of your screen, you'll see a chat with a speaking cloud over it. If you press on that, it'll open up the chat section. And if you look at the top of the chat, there's a question that I've posted, and this is the way I would like you all to post your questions, which is, first of all, state what the question is about. So in this instance, it's about PPE, and then follow it with the question. So we can then, at the end of the presentations, be able to group all those questions together. And Danny Benelli will be helping me to do that. If please note for all the participants that this session is being recorded, and it will be available on ACEM website as well as a number of other websites that we will make available after the session for people to be able to share with their colleagues. I would now like to introduce John Bonning, who's the President of the Australasian College for Emergency Medicine. John's been a specialist emergency physician for over 15 years and was Director of the Department of Emergency Medicine at Waikato Hospital in New Zealand. He's not only President of the ACEM, he is the Chair of the New Zealand Council of Medical Colleges. John.
Thanks very much, George. I apologise for my slightly vocal entry into the meeting when I was struggling to find the link. You'd think I've got used to using Zoom by now, having lived and breathed it for the last 2 weeks constantly. Thank you very much indeed, and what a wonderful collaboration and interesting meeting this is. It's an honour to be involved. As George said, I'm the President of the Australasian College based in New Zealand. We've been kind of running business for the last several weeks since we went into lockdown from our homes, although I still practice clinical medicine. The introduction from me is this is fantastic to have an international collaboration. It's in fact the second international meeting that I've had today. We met with our British counterparts at the Royal College of Emergency Medicine this morning. And had a long chat to them. It was extremely productive discussion of really key issues such as what to do with our very sick patients, but also what to do with our trainees, how we're advocating with politicians. Personal protective equipment seems to be something that comes up all the time. We're dealing with this slow-moving mass casualty, if you like. We've all dealt some more than others potentially with these huge mass casualty events, but this one is a once in a lifetime opportunity. Look, this is an amazing thing that actually we all train for. We train for mass casualties, and this is a once in 100-year event. It's been very, very tough in certain countries around the world. We're learning from the Italians, learning from the Chinese, and learning from each other. So I think this international collaboration is phenomenal. Getting to know how we approach the situation in our emergency departments, but also, as I've alluded to, how we deal with our fellows for wellness and how we deal with our trainees who have to deal not only with the acute aspects of the illness, but also their training and careers as we move on. So we've got unfettered access with politicians through our chief medical officers, which is quite amazing. And there's a lot that we're going to need to take into the aftermath of this amazing event in terms of doing things slightly differently. Our access with the chief medical officers, and then try to feed down into our members around issues such as personal protective equipment, not only for the high acuity patients, which everybody kind of focuses on, but also what's business as usual in an emergency department. It's people that come through the front door every day, and the fact that we perhaps are moving from having a, no COVID more into low risk COVID, for example, and that's been an all-consuming activity. So look, this is wonderful to have this collaboration. Guidelines is something else that we've been working on over the last week or two. And again, I think it's a great opportunity for us to share resources, share the way we approach this issue, share stories, and move forward. So I'm very excited about this. Hope to participate later in the conference. Thank you for the opportunity to speak. Back over to you, George.
Okay, sorry, I just had to unmute myself. I think there's been a lot of collaboration with Australia and Israel over the years, and we really value that association that we've developed. I'd like now to ask Dr. Mike Drescher, President of the Israeli Association of Emergency Medicine, to speak. Mike is a US-trained emergency physician who is Chief of Emergency Medicine at Bellinson Hospital, which is a level 1 center that sees about 150,000 patients per annum, and is part of the Rabin Medical Center, which has a 1,300 bed capacity. Thank you, Mike. You're muted, Mike. Your mic is muted, Mike.
Okay, thank you. Sorry about that. I was overly polite. Thank you, George. I appreciate the introduction. Dr. Bonning, it's nice to make your acquaintance. I thought that what I would do is try to, being very mindful of the time, to try to make the best of it, to give a little bit of where we are in Israel and a couple of salient points that I think that we've learned so far, understanding full well that we are not at the end of anything. We're maybe at the end of the beginning. We really don't know which way things still are going to turn out, but certainly there are certain things that we can discuss now, and I think might be of interest to the group. Can I have the next slide, please? Is that up to me to do? Okay, thank you. So where we are now, I was just looking at the Australasian numbers. I think we're not too far off of where you guys are, maybe a little bit ahead, certainly per capita. We have about 8,600 cases and about 140 of which are severe, maybe 100 are intubated, 40 or so deaths. So we're certainly not in any kind of a major battle right now, but we are at we're well into and kind of have been in the meat of the preparation phase where we are now mitigating. All of our emergency departments, 29 emergency departments in Israel, all have a respiratory or corona suspected area of their emergency department. Most hospitals have a suspected corona ward. Our hospital has an entire corona hospital now dedicated to admitting patients, where we have approximately 40, and around the country there are about 140 patients admitted with severe disease and a lot more with mild disease. The country's also set up a series of hotels where patients with mild disease but are still positive are being taken care of. Some of the points that I wanted to that I was hoping to bring up now. George, can you still hear me and everything?
Yep, we're all good.
Okay, good. I'm having a little bit of trouble with my screen here for some reason, but that's no problem. I wanted to bring up a couple of things that we've seen over the past month or so. And one of the salient things is that our emergency department census in general has decreased approximately 30%. Now we have this is not an official figure, but we have a very good communication system between all of our informal kind of social media communication system between our departments, and seems pretty standard, pretty uniform that 30% of our patient load is decreased, mostly the walk-in type patients, which is good news and bad news in the sense that it's relieved pressure and allowed us to ramp up the specialized response that we've had to have to deal with the COVID-19. But the bad news is that people are probably staying home who shouldn't. Some people are staying home who should, but we are anecdotally seeing people who are coming late to the hospital. In stroke, it seems to be less so, but in other things, perhaps chest pain, things like that, more. Which brings me kind of to one of the other salient points that I wanted to bring up, which is we are anecdotally seeing a delay, or I say a compromise in their standard of care of patients who have real disease, because I think in the emergency department, this has become part of our daily routine, dealing with PPE and dealing with the possibility of, or the reality of, COVID-19 infection. But some of the other departments are still not up to speed, and we're seeing patients who probably should have gone to one department or another for a true illness, which are being delayed, or questions are being asked because they have possible COVID-19. And I think that's an important point to take home, which is that not only does the emergency department need to be prepared, but really the other hospital departments need to have a way to take care of open fracture with COVID-19, heart attack with COVID-19, stroke with COVID-19, etc. The next point that I want to make, which I think is possibly, I don't know if it's unique, but I haven't found too much about it in the literature, because we're hoping to publish our experience in the use of our national emergency medicine pre-hospital system, Magen David Adom, for testing the public for COVID-19. Most EMS dealing with pandemics in the literature that I've seen has dealt with evacuation and treatment of patients in the pre-hospital arena. But we were initially, when we began to enter into the ramping up phase of testing, epidemiological testing, we found it to be very burdensome because it fell to the emergency departments. The Ministry of Health came up with a plan with Magen David Adom to have their pre-hospital crews go out and do testing in the home for patients under isolation, which served several purposes: keeping the patients out of the public, keeping the emergency departments freer for taking care of patients, etc. And we found that to be very useful. And Magen David Adom has done thousands of tests in patients' homes, and now has opened up freestanding public testing facilities, which is I won't go into more detail for lack of time, but we found that to be quite a helpful instrument, and I think it should be noted. John mentioned exam training. Well, all of our training has had to undergo a bit of an alteration in this period. We have had to put off of our exams. We've had several exams which are going to be put off to later. This is a difficulty, but it's a necessity, and I think that it needs to be dealt with, as so many other things in life as we go through a general kind of decrease in our public activity. One other thing that I wanted to bring forth is to pay attention to special populations. The entire country has gone into a relatively rapidly increasing severity lockdown or social distancing, or somewhere on that spectrum. If there are populations who are not as exposed to the general internet, television, mass media, or for some other reason are not on board on the same page with the rest of the societal preparation, it can be a problem. And we have, I wrote down the Bnei Brak example. Bnei Brak is a ultra-Orthodox neighborhood, very heavily populated, very densely populated area, very close to our hospital and to other central hospitals in Israel. And it turned out that really there was quite a delay in their understanding of the degree in which social distancing needed to be taken into account. And we are probably now seeing a second wave, although it's still not overwhelming in any sense, but it's a clear and present danger needs to be addressed, in my opinion. And the last thing I want to just make mention of is the PPE issue. Thankfully, we don't have any shortage, but there is still a great deal of concern. So amongst staff and amongst the general population, I think that there's two things that we have done, which I think are most helpful. One is to standardize things, and the second is to publicize the standardization. As soon as one area does something more because they think that, or one hospital or one organization goes another step further than what's recommended by best practice, it quickly becomes a question of why aren't we doing that at every other place? So the most important thing, of course, is to do things safely. But once you're at that point at which the experts can tell us this is safe practice, gloves, surgical mask on us, most importantly, surgical mask on the patients and the visitors, and all of our visitors, all of our patients, and all of our staff are now wearing masks. That is the standard, and that only to increase when you do an aerosolizing procedure do we upgrade to something else that keeps because one of the things I remember reading from somebody who gave a report from Italy was that one of the things they were dealing with was PPE shortage due to staff misuse. And I think that this is key. So far, I think we've managed that reasonably well here. With that, I guess I will, George, if you have any questions, if there's anything you would like me to address within the time allotted. If not, I'll, as they say, yield back my time.
And as I said, we'll continue through the presentations and encourage people to please use the chat function. Others have started, and I think it will be good for us to be able to collect questions to ask our participants. I'd now like to introduce Professor Jacob or Kobi Assaf and Dr. Ahmad Nama from Hadassah Hospital in Jerusalem. Professor Assaf is the Clinical Visiting Professor, Faculty of Medicine, Hebrew University, Director of Emergency Medicine Department at Hadassah Medical Center in Jerusalem, and Ahmad Nama, who actually trained with us at the Royal Melbourne Hospital for a year as an emergency medicine fellow, is now consultant emergency physician, head of the emergency medicine unit of Hadassah Medical Center in Jerusalem. I'll hand over to both of you. When you unmute.
Oh, sorry. Okay. I'm sorry, we have a problem here, so I could not put my presentation on this computer, so I'll talk without it. First of all, it's a real pleasure and a good idea to do this talk together. And we really have the crisis challenge us with a really special situation, and things are changing all the time, and we have to keep up with the changes. And as a matter of fact, to learn everything on the go. And every day we have a new either idea or situation, and we have to cope with it. From the hospital point of view, I think that the main goals are, first of all, to provide high quality first line care for the regular ED patients and the regular hospital patients. And the second is to ensure appropriate treatment to the COVID-19 patients. And the third, and I think the most important one, is to ensure the staff and the patient health and safety by reducing exposure as much as possible while meeting the patient's needs. The major concern is the risk of dissemination of this infection. And because of this, the hospital was divided. First of all, we divided the emergency department, and Ahmed will go into details later, but we divided the emergency department into two main parts. The one part is the regular one with the ambulatory area, intensive care area, trauma unit, and so on, and the pediatric area. And the other side is what we call the biological site or the corona site, which is an isolated place guarded by security people, and people can go inside only when they are part of the staff and only when they are protected appropriately, and it will be seen later. From the hospital point of view, we constructed specific wards in the old building. As a matter of fact, the old building in Hadassah became a corona hospital. We have the few beds, few departments. One of them with 38 beds, the other with 6 intensive care beds, the other with another 38 beds, and within few days, we open another ward with 20 beds. So altogether, we will have 102 corona beds. Of them, what we call Mikorona will be medical intensive care unit of 50 beds within these departments. The exposure and contamination among the hospital personnel is a major issue, and I'll refer to it in a minute. But just to say that till now, we admitted in the contaminated area 394 patients. Of them, 54 were positive for COVID-19. We had a problem at the beginning dividing them into, highly suspicious and mildly suspicious, but we saw that the percentage of positive for COVID-19 was the same, which is about 14%. So you never know if the patient you are treating is COVID positive or not. And this is why we decided to use the same protection gears for all the patients and not according to the degree of suspicion. As I said, the main problem is the contamination or the concern about the dissemination of infection within the hospital. And according to data, and according to data from the country, as for 2 days ago, we had medical personnel, 1,695 people in isolation, and about the same number because of exposure. And within this, in the country, more than 700 nurses and more than 300 physicians are in isolation, which means they do not function in the hospital. So as I said, this is a really major concern. The same is in Hadassah, in smaller numbers, of course, but we have about 70 nurses that are isolated and a few tens of physicians that are not at work at the time. There are many possible, of course, points of exposure, like treating symptomatic patient, physical examination, when you are treating the patient with aerosolized procedures, like intubation, like CPAP and so on, X-ray, blood tests, and you have to take care of all these procedures, and I believe that Ahmad will go into details with these issues. Because of all these problems, we tried, first of all the personnel was instructed not to come to the hospital even in mild cases of, running nose or itching throat or fatigue or something. But in addition to this, we started doing screening tests for all the personnel. It's a real problem because very soon the laboratory was stuck because of the number of the tests. Some of them from the hospital, some of them from Magen David Adom, and the number are that the first week, which is about a month ago, the laboratory did about between 100 to 200 tests per day. Within a week, it came up to 500. A week later, to 1,700 tests, and now we went back to 900 because of shortage of reagents, which is all over the country. So these are the major points I thought to make from the hospital point of view, from the personnel, and mainly, as I said, which I see as the major point, is stopping the dissemination of the infection within the population, but mostly within the hospitals. And I'll ask Ahmed to take on from here.
All right. Hi, everyone. Hi, George. Hello?
Yeah, we can hear you, and we can see that your screen is being shared of the emergency department photos and map.
Okay. So let's start from the beginning. So about a month ago, when we decided to do all these changes, the first thing was, where do we actually treat these patients? So this is just have a quick look at our emergency room map. We have a dedicated area, which is the biological / the respiratory area at purple there. This is actually the big area. This is the main room where we used to treat our everyday patients. That area is the biological zone. As you see, it's a one direction. You have a dressing room. We built in a dressing room. We can change the clothes as you leave the room as well. It's a one direction. But for these changes, actually, can I move for a next slide? For these changes, we need to do some immediate changes. So the first thing, we had to close our observation unit. We have a 12-bed unit. We had to close it in order, we needed some space to treat the everyday patients that they come in. We did open within 2 to 3 days, immediate another extra 6 beds for 6 patients, which are resus rooms. And regarding pharmacy, of course, we had a drug room or a pharmacy inside the biological zone. We have one room that it's dedicated for both trauma and old resus area and the new resus area, which has the 6 beds. And of course, we have another one at the waiting room area. So next one. So as you can see here, this is the room inside. This is the biological zone, basically, where we have 27 beds overall. 16 beds of them, they are resus beds. We did have, of course, to open a room for ophthalmological exams, which is the dirty zone or the biological zone. We do have a room which is clean for patients who are not suspected for COVID, but we had to open one. So everything we have a double. So there is 2 rooms for ophthalmology, 2 rooms for gynecology, for gynecological exams, one of them in the biological zone, the other one is in the clean zone. And next one. So let's just have a quick look what happens today when a patient with, what's happening at the triage. So patients presenting to the emergency room, they are divided into 3 categories. So these ones which are confirmed, basically, they don't come inside to the ED. They go to the area where there is a COVID positive patients at the old building of the hospital. The patients who have a quick triage, which are not suspected for a coronavirus infection, they get the treatment as in a routine manner. But those patients who are suspected, they are divided into another two two groups. There is low-risk patients. From these low-risk patients, there is ones that they are easy cases of Cat 5 or Cat 5 that they just come in, they want to be examined for some reason. They might have a fever, they might have a runny nose. These patients still also, they don't come inside in the room. We do for them the exams outside or just at the entrance. We have a dedicated room for that and we send them home. The other two groups, which is low risk, what still need to be examined, the high risk patients that need to be examined, they enter the biological zone. Next. In the left side, you can see mainly the entrance of the biological zone. There is this door with a small window where you can see actually the staff inside. As you might see, probably someone's inside is already dressed. In the right side, there is the entrance to the dressing room. In the right side, this is mainly our protocol for dressing for PPE. Everyone has to be covered from head to toe, so including the hat, goggles, N95 is a must, and waterproof shield with basically gloves as well. Next. So what happened is basically not all the patients when they come, they don't only come for suspected coronavirus, right? So they might have a runny nose, fever, etc., but still they need to enter this biological zone. So we do still do the routine tests and routine exams as in ECGs and of course all the pathology. We do face some delay. It's about, let's say, roughly about 1 hour, 1.5 hour delay in overall tests that we take from pathology. Every patient enters the biological zone, we do send a COVID PCR. Two things about the COVID PCR. It has, as Kobe mentioned, there is a really big number of patients doing the COVID exams, and there is actually a processing time. So once you take the test, this test needs to be transferred to the lab. It will take about somewhere between half hour to 1 hour until it reaches the lab. And once it's there, there is a processing time from 4 to 6 hours. So the best case scenario, once you send the test, we do have a fast track. You put it in the fast track, you handle it manually to the patient, to people in charge at the lab. It will take about 4 to 6 hours, which is, it could be sometimes a struggle for us. This is one of the biggest issues that we face currently at managing these people at the ED. Chest X-ray, we have a mobile chest X-ray. It's inside in the zone. All the technicians, when they come inside, they do the same PPEs as we do with N95. They come in a 1 hour basis with all the disadvantage of only one shot at bedside. So you don't have the lateral view, you don't have the PA view, but still we do for every single patient entering that room. Ultrasound, due to the fact that the chest X-ray is delaying, due to the fact that there is a CT limiting the CT scans, we use more ultrasounds, lung ultrasounds mainly for the routine things that we used to do, but also just there. CT scans, we try to limit the CT scans as first to decrease the exposure, mainly for safety issues. So we do CT scans, I think in 1 hour every 2 hours, where there is a patient that need to be sent. We do have 3 CT scans at the hospital. One of them is dedicated for suspected coronavirus patients. Once we order the CT scan, there is a duplicate that we built in the CT that need to mention that this patient is suspected for a coronavirus. And once you order the CT, the patients leave with a security to the CT scan. There, everyone is protected. They do the CT scan, and once they are back, they need like a 1 hour protocol of cleaning that machine. So this is basically how we do the CT scans. Regarding intubation, I think most of us know the routine or the common intubation list that we have it for every patient, but we thought probably to do some minor changes with the intubation checklist dedicated for COVID patients. So the clamp, it's not in the kit for intubation, so it's there now. Of course, do the rapid sequence intubation is a technique, We try to avoid using AMBO, but if needed to, for some reason, need to be used, it must be done with the filter, HME filter. And as you might see, it's like it's similar to the usual ones. So the pre-intubation, post-intubation plan, everything should be done. We try to limit the staff inside once there is intubation. So 2 to 3 personnel, not more than that. So 1 or 2 physicians, 1 nurse, everything is ready and start the intubation. We tend to go probably for early intubation and early intubation process for all the reasons that we know, for aerosols exposure and etc. The senior ED physicians or some well-trained or anesthetist should do the intubation. It's not the time to train or to do any training for residents at this point. Beside that, we try not to use the BPAP and the CPAP, but we do use it for few patients that probably we know that they might need it. We still want to avoid intubation, and they are at a low risk. We did brought these masks which are good for sealing, and they prevent actually sealing of air, and we can use it. We don't use it every day, but if needed, and we try to avoid the intubation for a low risk patient, we still do that. So just to mention a few words about the staff and rostering, our everyday roster, it didn't really change. I know that few of our colleagues, few of our other hospitals in Israel, they actually changed the rosters as 12 hours work, 24 hours break or something like that. But our working hours still in the same. So we have the morning shifts and the night shifts actually. But we did do some divisions in the staff. So we have a dedicated staff at the waiting room in the ambulatory care, dedicated staff for the resus room, and for the biological zone there is actually let's say there is a staff that need to be in a rotation every 2 hours, but also not every day. So they are not exposed every day. It's very frustrating to enter this room for 8 hours or 9-hour shifts, although there is a rotation. So there is no crossing between the teams. And one important thing to mention, that people or our physicians who are in a high risk age, diseases, and even pregnant women, we have some treating physicians with a beard for a religious purpose. So these patients, where we define them as a high risk, they don't enter, so far, they don't enter the biological zone at all. Next. So if I want to sum up our numbers, so far we saw about 394 patients, and 54 of these 394 entering the biological zone were actually COVID positive. The age was about 51. The last 2 sentences I want to mention, actually, the psychological effect at all this COVID, there is 2 things. The first thing, there is a fear from the patients and fear from the staff. So we have some treating physicians that they actually, you could see probably they are anxious about entering the biological zone. So there is one thing that we have noted at that point of view. The other thing, the patients as well. So many patients, they would come, they would actually hide. They would tell you, oh, I'm not coughing, I just came here for chest, I just came here for a chest pain, or they would probably not to mention why they came here for. And the other important thing, we are treating patients, both the patients are with a mask, we are with a mask. These face mimics actually are not present. So we don't actually, there is no this visual emotion that we usually treating, it's part of our treatment. So we have lack of this thing. That's
Thank you. Thanks, Ahmed, very much. There has been some questions that have been raised while you've been talking. We'll try and get back to them. But I am mindful of time, so we'll get the screen returned, and I would like to introduce our next speaker, which is Dr. Avi Aroni, Director of the Emergency Medicine Department at Sheba Medical Center, Tel HaShomer in Tel Aviv, a level 1 trauma center and one of the first COVID centers established in Israel. Avi is an internal medicine trained emergency physician, undertook a fellowship in resuscitation in Canada between 2008 and 2010, and has been director of the emergency medicine department at Sheba since 2017. He's also the coordinator of the National Emergency Medicine Fellowship Program. And I'll hand over to Avi. Thank you very much, Avi. And if you can unmute yourself.
Yes, so hello everybody. I will speak about our experience in Sheba Medical Center, which is a large hospital, one of the largest hospitals in Israel. We have usually about 350 patients a day on a regular basis. But since the Corona crisis, we have been a reduction in the number of patients. So as we started, can I go? What? Sorry for this. How can I change the? All right. So, sorry for this. Can I change the slides or?
Jorge, you need to unmute yourself to give directions.
Yes. No.
I stop sharing and you start sharing yourself. Okay.
Oh, okay.
Give me a second only. Okay.
I can.
So you can share now. You can share.
Okay. All right. Thank you.
Now you can share.
All right. So as the crisis started, it started.
Try again. You are not sharing it. You are not sharing yet. Just try again. Sorry for the technical issue. Just do share screen now.
All right.
Here you are. Yes.
All good.
Now we are in control. Go to slideshow.
Okay. Fine.
And you can move from there.
All right. So the crisis started gradually, and we started to organize. Then suddenly it caught us in a moment, and we had two physicians that came from Italy, and they were detected as COVID positive. So in one day, out of 28 physicians in the emergency room, 23 of them went to isolation. Out of 90 nurses, about 50 went to isolation, and suddenly we were left with no staff. Fortunately, the hospital manager gave us some backup, and we built 4 teams of nurses and physicians, and gradually when they came back later. So I myself went into isolation, and the hospital built for me a headquarters in my room. So via some close videos, monitors, and through my computer, I could help the staff manage the emergency department through the telephone. It was quite an experience. Next, about the staffing. So we built 4 teams that every team was a compound of physicians, nurses, secretaries, and so on. And they were working together for 12 hours and changing, no crossing between the teams. And it was important that if somebody of the team was sick, so he would not contact all the other. And this worked very, very good. About the prophylactic PPE. So we use the same cytotoxic or chemical grown. We have special cover for the shoes, and this hood was developed by one of the secret units in the IDF, and we get it so it cover all the neck. We have the screen here and the N95. So we give N95 for everybody is taking care for the patients, and if they're taking care for the high suspicious patients with COVID, so they have this clothes. And from our approach was to divide the patients to suspicious and non-suspicious. So everybody is not any suspicion went directly to the regular AER, and the patients that are suspicious were divided to three levels. The green one was that you have some history or exposure, but no symptoms of corona like broken hand. And the yellow will be symptoms plus minus history, but he can walk. And on the red side there will be people that on beds that cannot walk. We divided the emergency to those parts. The green section were run outside the hospital. The yellow was here in the parking lot of the emergency room, and the red section was inside. We had a hall with about 30 beds, with the 2 under pressurized rooms that we can handle those patients that were highly suspected or with corona positive. But our approach was that we should do it in the out of the room, and the air will take out the risk of self-infected. In the entrance of the emergency room, there was a triage nurse, and she was dividing the patient to the corona emergency room or to the regular emergency room, and we use walkie-talkie to connect between ourselves. Outside the hospital, we built 2 tents that were taken from a special unit in the hospital that build those field hospitals in the disaster areas. So and we have here the problem of the very hot season. So we built a cooling system inside, and here we take care for the patients that we do the vital signs, need the ECG or whatever it needs. And then they will go out to the what is called the parking. Here we built special rooms, and now they are equipped with heaters or air conditioning. Depends on the weather, but we can separate them from each other. Another very interesting thing that we built is a machine, kind of very primitive machine, that we can take swabs without contact with the patient, and later on we clean it. So it is very primitive, but it's very effective. And now in the red area there is the hall, and we are it looks like as we saw in Hadassah, but we have some cameras to see the isolated patient. We have monitoring those, because in those isolated rooms with low pressure, it is very difficult to monitor. So we have the cameras. It is very important that we build some rooms that will divide the patients that once they are moving from the infected areas to the clean areas. And here it is an example, and we have some HEPA filter that can move the air or filter the air from those sides. So in general, we about the radiology, we built another suit specially for those cases outside, and we use it outside, and we try to not to move the patients in. In general, we have about 100 patients a day in the corona area. About 75 of them will be managed by the walk-in clinic, and only 25 will go into the red zone. Out of this, we have about 18% of corona positive patients. Means that we had until now about 400 positive corona patients. I think this is it. Anything else?
Thank you very much, Avi. That's great, and it's really interesting to see the ingenuity that had been created for taking swabs, which reminds me of milking a cow as well, but certainly was good for patient safety. There was a number of questions that have been raised regarding the protection of healthcare workers and cross-infection, and looking at the photos that were presented, the extent of PPE that is being used. I might turn back to Mike, who talked about standardization in the beginning of his talk about the PPE across Israel per se.
Yes, George. So, initially there was we had some we have expert opinion that came out fairly strongly saying this is what you need for PPE standard, and this is what you need for PPE in aerosolization procedures. Those are basically the two categories that people have used. Now, the problem is that it's always, there's a suspicion that especially amongst staff, that we're holding back, or that you could do better, or why not use the N95 all the time? Why not use we even have these motorized, they call PAPRs things. Why not more? Why should we even leave anything to chance? And so there's a very natural tendency for things to spiral. So if people see that one place is using something that's a little bit extra, then why aren't we using it? So it's very important, number one, to be correct. And apparently it is correct that surgical mask on the patient, surgical mask on the provider, plain gown, gloves, and a face mask is what you need to keep safe. And we've seen there's been polling in some surveys done in Israel now that people are appropriately gowned and prepared that way. There's virtually a 0% chance of cross-infection for the normal encounter. Now, so it's very important though that this come out as a policy, that everybody can see that this is what we're doing. Whether or not you impose on people, don't do more, that's kind of a political question, because there are people who are going to say, well, I want to do more. I want to take the N95s. And if you have no limitation, then I guess there's really little problem, even though even that's not true. But the point is, I think that when we come down to it, we need to be correct and use best evidence, and then stick to it for the sake of using the more higher grade PPE when it's needed, for instance, in an aerosolizing procedure and some other rarer cases.
Thank you. There have been a couple of questions about screening and community-based transmission. I don't know if anyone wants to comment. What's Israel finding in terms of community-based transmission? Are you still having new cases come from people that have come from overseas, like the Italian example that Avi gave us, or is there now evidence that you are getting community rate?
George, I'll take that one. We discovered in Beilinson the first non-foreign or traceable to a foreign contact patient back in late February. And since then, basically the country has been shut down to foreign travel, essentially in and out. And so everything now basically is community acquired. And so and as to the screening, This is a big question, but for right now, there's just not enough. We don't have enough tests right now to do mass population screening like people have been doing in, I guess, in Korea and I think in Germany, some other places. We don't have enough tests to do that, so we're not there. But there's a lot of discussion of it as the next step. Once we've done mitigating, that we need to find out where exactly the virus is left, and so that's probably next. Are you guys doing it, screening at this point in Australia and New Zealand?
No, we've certainly got case definition screening still. We're starting to liberalise it a little bit, but certainly in Victoria where I am, it's pretty much restricted to case definition. It's also going to ask, raised about special groups. A number of special groups have been identified in the chat. There was a mention about the ultra-Orthodox religious in B'nai Brak. There was a question about the Gaza Strip, and someone had said that Ramadan is approaching and how social isolation how successful that be practiced amongst those sorts of groups. And again, I'm not sure if anyone else wants to comment on that.
Well, just before, if there's nobody else, I'll say before Ramadan, we have Passover. And the Passover Seder in Israel this year is going to be different from anything it's been in the past, memorable history. And so I think the same questions will apply. There's no question that these are challenging times, and it's really incumbent upon the government or whoever else can change public opinion and make it clear that this is this night will be different from all other nights in many respects.
Okay, I'm going to move to another question, which is one that is very frequently posed, and that's the question of CPAP. The person who posted the question said, why is ANZICS, which is the Australian New Zealand Intensive Care Society, banning CPAP when it is used by WHO, UK and the USA? And I just wonder if anyone from Israel would like to comment on the use of CPAP.
I'll do.
Okay.
All right. So we try not to use BPAP as much as it possible, and we know now that there are two phenotypes of respiratory failure or patients with respiratory failure, and we try to move as soon as to early intubation for the patient. The problem that we don't really know if the patient is COVID positive or COVID negative. So we try to figure it before use it. And as Ahmed said, we use a special mask that is sealed, and we use it through the regular ventilator and not through the usually BPAP. So we use it attach a special ventilator to it of Hamilton, and we try not that there will not be a leak of air, but we try to minimize as it possible.
Okay, now we've got time for one last question.
George, if I could, piggyback on that last question.
Sure.
It seems like that the respiratory failure, at least from what we're hearing, is very, very highly hypoxic and not so much hypoventilation problem. And so people are using high flow oxygen, which has the same kind of aerosolizing problems. And so I'm not exactly sure where this is going to shake out, because it seems like this is possibly a way to keep people off of the vent, either in general or at least delay it. On the other hand, it's not recommended. And we have the Israeli, the Ministry of Health has come out with the guidelines for ventilation of the COVID patient, and it does discourage non-invasive ventilation of any kind because of the aerosolization. But I think that may be too broad.
So you're like all of us, we're still sort of trying to struggle with this in a little bit. The last question is really about the way you structured your emergency departments, particularly with the respiratory or biological zone. And the two questions are, how have you controlled cross-infection moving in and out of the respiratory zone, and what air filtering systems are used in the various departments when you're dealing with biological contamination or risk from COVID patients or suspected COVID patients?
George. Audio problem here. I would like to refer to a question, and I think the problem of cross-infection is more theoretical than practical. Why? Because of two main reasons. I mean, within the department, I'm not talking about corona wards where all the patients are corona positive, but if we're talking about the Department of Emergency Medicine, according to our short experience of as I said, about 400 patients, about 15%, 14% are found at the end to be positive. It means that when you are walking around the department, you don't know who is positive, who is not positive, who will be positive. For you, you have to relate to all the patients as if they are positive. Okay? So we use the protecting gear and everything. Now, the problem is with the patients, of course. So usually, if not necessary, they do not get out of the beds. They use face masks, and the curtain around the bed is closed. And we hope, because we do not have a cubicle with the real walls, and we hope that this will prevent the dissemination of the virus in the air. But at the end, we don't know. If we talk about cross-infection, let's say that there will be two patients at adjacent beds, yes? And one was positive, the other was not. The one who was not positive, go home. He goes home, and do you know if he's infected? No. If you do a test, a PCR, 2 days later, 4 days later, 5 days later, it doesn't matter. The fact that he will be negative doesn't mean that he's not infected, that he was not in a close call. So I think that practically we cannot have a real information about cross-infection. I think that the danger is there, is real, but I think you can minimize it if you keep the personnel protected, and if you keep the patients in bed surrounded with curtains and with face masks. It will be much better if we have a special cubicle for every patient with negative pressure, but at the moment it's not practical, it's not there.
May I say something? George?
Yes, please do.
So all the cases of personnel that was infected in the hospital here in Sheba was due to meeting other personnel or other family members. There is not documented one case that the personnel was infected or by a patient. So it is very important that we keep all the regulation of contact precautious.
George,
Okay.
if I may I just comment 1 second. What Avi says is key, but it's in the country. There have been people who have been apparently affected by across from patients, that are healthcare workers, but nobody who has been appropriately in PPE and appropriately by the Ministry of Health standards, not by excessive standards, has been infected from a patient. The other thing that's important to remember is just the mechanism of transmission. I mean, this is a droplet disease. And I think somebody in your question, George, had mentioned air filtration or something like that. It's really not necessary because, you know, if you keep the patient isolated by droplet precautions, you should be okay. We do have negative pressure rooms, but for instance, we tried to do intubation in our negative pressure rooms and we felt like we were so less comfortable there and things were so much less set up as we're used to, that we are going to do more damage. So we do our intubations in our regular rooms and then move the patient if needed into negative pressure. But we don't want to throw out the baby with the bathwater. and we need to take care of our patients and not hyper focus on the corona at the expense of other things. So that'll just be my point.
Okay.
George, could I raise another question, please? A short one, because it's we find it as a real problem. Is it possible, according to your time schedule?
According to my time schedule, not. I know that I'm surrounded by Israelis and it's hard to keep to time, but Kobi, I'm going to have to be very dogmatic here and say that we said that we go till 7 o'clock and we have run out of time. So I think we will have to leave it for the moment. Thank you very much. It's been a great session. Lots of interaction, lots of questions. There have been questions that we haven't been able to get through. I will work with the organisers at Hadassah, George and others to make sure that we can keep the lines of communication open following this session so that people can follow up any of their questions with any of the speakers and just make sure that we have covered off everything that people have asked in their questions. So on behalf of the people that have organised this, the Hadassah Foundation, both here and in Israel, Danny Benelli, who's assisted me in coordinating this, and of course our speakers with the support of the Israeli Emergency Medicine Association, as well as the Australasian College for Emergency Medicine. I'd like to thank you all. For those having a good Easter, have a happy Easter. For those going into Jewish Passover, have a good Passover. And for those that are going to Ramadan, have a good fast. So thank you all for participating, and I hope you got something out of it. Thank you all.
Thank you, George.